والله سنتين The second assertion is an assertion I established that we have the Canadian upper tract collaboration, and that includes pretty much almost all aesthetic centers in Canada. A lot of the results in my slide will be from both approximately 6% of all European tumors. We also know that the recurrence in the contralateral unit is somewhere between 20%. The majority of upper tract tumors happen in the upper tract PCC. Approximately 30 to 50% will develop in the future in latitude. A lot of risk factors are common among upper tract PCC and due to the ingestion of the Chinese herbivores and lipoic acid. Areas in Taiwan where they have a high concentration of arsenic in water, either a CT urogram or an MRI urography for detection of these filling defects in the uterus. With regards to cytology, we know that the sensitivity of uterine cytology is less for upper tract disease than the bladder. We also know fish, urovision has been studied extensively in the bladder. There is only a few studies looking at it in the upper tract, the diagnostic procedure of choice of confirming the presence of disease in the urethra. Although it's not always indicated to for management purposes. That we can talk about later. So what are the indications for conservative management? When I talk about conservative management, meaning management with endoscopic approach or percutaneous resection. And those patients are patients who have typically low-grade tumor on biopsy, a negative cytology, unifocal tumors, small tumors, ideally less than 1 centimeter. And most importantly also, the radiological imaging does not show any infiltration of renal parenchyma or periurethral standing suggestive of an invasive picture. And patients have to agree for a stringent follow-up if they elect to be treated conservatively because it entails repetitive uroscopies, particularly in the first 2 years of follow-up. Is there any role for upper tract distillations, be it mitomycin or BCG? A few months ago we published a paper, basically it's a comprehensive overview of all the papers looking at the efficacy of upper tract distillations in upper tract tumors. And basically the conclusion is for carcinomycetic of the upper tract, BCG works well, 70% early response, and the progression is roughly around 3 to 5%. Again, the follow-up is limited, but it appears effective for upper tract disease. However, BCG in the adjuvant setting after tumor resection, particularly for TA or T1 disease, it does not seem to work as well as carcinoma in situ, with a progression rate roughly around 40 to 50%. And all these studies are limited again from small sample size, short-term follow-up. If you do elect to give upper tract installation with this disease after conservative management, there's 2 guiding principles. 1, perform this installation under low pressure and the absence of infection. A couple of approaches, you can either give it anti-gravity through a nephrostomy tube, and it is my preference of doing that because I feel that the BCG bathes the urothelium quite well with this approach. However, you have to be careful because you can get life-threatening sepsis due to this approach. And the other approach is either retrograde directly through a urethral catheter or through a reflux with the help of a double J stent. If you're about to do the anti-vein perfusion approach, always do an prostogram to make sure there's no obstruction, there's no pilovenous or pilolymphatic backfill. If there is a neobladder involved in place, put a Foley catheter in the neobladder to drain it. And the BCG should be in stent at a rate of 1 cc per minute at no higher than 20 to 25 centimeters of water as a pressure. You should keep the patient for several hours afterwards to make sure they don't go septic. If you're entertaining the possibility of retrograde installation of the treatment, again, 2 important things you need to take into account. 1, you need to confirm reflux because we've known studies have shown that up to 40 to 50% of patients with double J stents don't have any reflux. So you can give all the medication you can in the bladder, it's not going to go up, it's not going to have any chance for it to be working. And the other thing is you need to also do cystograms with varying volumes to establish at what volume you get reflux all the way to renal pelvis. And there are some patients that you can have 100 cc's great reflux to renal pelvis. Some patients you need to instill up to 200 to 300 to have that reflux going up to renal pelvis. So there have been newer technologies that have been used in bladder in the help of improving detection of tumors, such as narrowband imaging, which accentuates the tumor vasculatures, potentially improving detection of tumors in the bladder, or fluorescence cystoscopy. The advantage of these maneuvers is actually what you need. You cannot have tangential viewing. You need to look at the thing head on to better detect it. In the upper tract phenomena, because the viewing is tangentially, I believe this novel imaging may have limited usefulness in this setting. So what are predictors of muscle-invasive disease in the upper tract? And it's important to know that because it may help also guide which patients you want to, may not want to offer conservative management. And several predictors have been associated strongly with invasive disease. One, high-grade hydronephrosis. Two, local invasion on imaging, infiltration of renal parenchyma or periurethral standing. A positive cytology, high-grade biopsy, sessile architecture versus papillary architecture, and a large tumor burden. All these have been shown to have an association. Again, it's not a 100% association, but an association with invasive disease that you can use to counsel patients on approach of treatment. And why is it important to know what's invasive disease? Because we know, look at the outcome of patients treated with nephrectomy. One stage, other prognostic factors that have been shown to impact. One is obesity, performance status, lymphovascular invasion. The presence of extranodal extension is just as important in bladder as it is in the upper tract. A lot of necrosis on IHC, sessile architecture. As Dr. Al-Ghanay mentioned, concomitant carcinoma in situ is not just as important in bladder, but it's also important with upper tract disease as well. What about age? I'm showing this study mainly to illustrate that, yes, although with age you can have an increased risk of complications from the procedure, there's a lot of octogenarians that pass through this procedure well, and the surgery is associated with effective outcome. But it shows that even an octogenarian procedure is feasible, safe, and efficacious. What about tumor location? Historically, tumor location has been shown to be prognostic, based on the theory that if you have a tumor in the renal pelvis, the tumor location is not prognostic. When we looked at this in the Canadian collaboration, we've actually shown and published that it's not really the tumor location that's important, but actually the multifocality. So having tumors both in the renal pelvis and the ureter is much more prognostic than either the renal pelvis or the ureter. So if you look at EAU guidelines, they have a nice flowchart, with regards to the approach and management of the disease. And as I mentioned earlier in the slides, every patient should have some kind of CT urography, cytology, cystoscopy, uroscopy, and biopsy with selected group. How can we do it? We can do it open, we can do it laparoscopically, we can do it robotically. Is one better than the other? I have to say that it has not been shown that laparoscopic rectomy in this urectomy will yield similar outcomes. How do you manage the distal ureter? There's several ways of managing distal ureter. You can either manage it extravesically, you can go transvesically, you can use the endoscopic approach. All these ways have been written and described and published in the literature. When we looked at the management of the distal ureter, and you have in the audience who led this project, basically we showed, similarly to the group by Zionis, the international group of upper tract collaboration, that the fact is endoscopic approach seemed to be inferior with regards to bladder, intravesical bladder recurrences compared to the transvesical or the exvesical approach. Do we need to do a node dissection in this patient? This is a hot topic, lots of controversy, and unfortunately it will never be answered through a randomized trial because you need a lot of patients, and this disease is so rare enough that those things don't happen in a prospective fashion and also in time-limited fashion. But looking at retrospective data, it's clear that the more nodes removed in node-negative patients, the better the survival. However, the more nodes removed in a positive and non-positive patients has not been associated with better survival. This leads you to believe probably it's more just a staging accuracy. If you take 20 nodes out that are N0, probably this patient's N0. If you take 2 nodes out that are N0, there's a good chance this patient's N+. So I'm not convinced that node dissection in upper tract disease is of therapeutic benefit at this present time. And let's say if it potentially is, then what template you need to use? God knows, there's upper tract disease can go pretty much anywhere in the body. So if you really want to be a purist and you believe that the node dissection is impactful, then patients can have a nephrectomy with a full retroperitoneal dissection. And to me, that's probably a bit excessive, with potential morbidity without any associated definitive benefit at this present time. So in my opinion, the thrombectomy for upper tract cancer provides optimal staging, but I'm not sure at this present time it provides any therapeutic benefit. Template of thrombectomy, not clearly defined. And no trials have shown to have impact on survival at this present time. What about perioperative chemotherapy? Well, adjuvant chemotherapy has been studied again in a retrospective fashion, as this is a rare disease difficult to study prospectively. But suffice it to say, these studies have not shown any benefit of adjuvant chemotherapy in upper tract cancer. We looked at this for the Canadian network, and we looked at reasons why could this potentially be the case. If you look at the patients who underwent an nephrectomy, and you look at EGFR less than 60 as a parameter not being platinum-based eligible, the majority of patients are actually ineligible post-nephrectomy. Only 18% of the patients would be able to receive platinum-based regimen after nephrectomy if we would want to give it. But it's showing that there could be a biological effect similar to overseas bladder. Complete response, 14% of patients receiving. Considering the adjuvant chemotherapy, the following factors may help cancer patients. One, make sure your biopsy rate is high. Sessile tumors, the tumor has a large burden infiltrating the renal parenchyma. All these are important, and more importantly also added renal function from plasma-based regimens. So all this is backed by pure extrapolation from the bladder and taking into account what happens to renal function after taking out the renal unit. One caveat, patients who have adenopathy, hilar or regional adenopathy, there's no controversy. In this patient population, they should receive systemic chemotherapy as definitive treatment, followed by surgery after. Because we're not talking on the adjuvant setting, we do have documented evidence of advanced disease. We're looking at the biopsies positive. So what happens after you do a nephrectomy for upper tract DCC? I usually follow the EAU guidelines. And typically in patients with non-invasive disease, they get a cystoscopy at 3 months and annually. In patients with invasive disease, they get a biannual CT scan along with cystoscopy in 3 months and annually. In patients that are offered conservative management, they get more frequent cystoscopies and uteroscopies, 3 months, 6 months, and every 6 months for the next couple of years and annually. All these are based on grade 3 recommendation just because most of the data is retrospective. So conclusions. Elective nephro-sparing strategies have gained acceptance in patients with low volume, low grade disease. Radical nephrectomy remains the gold standard for high grade disease. Distal urectomy is a valid option for unifocal distal ureter lesions. Lamp and robotic nephrectomy are acceptable techniques with comparable efficacy. A complete excision of bladder cuff is mandatory. Endoscopic approach is possibly inferior, based on these retrospective studies published. Cystoscopic surveillance of the bladder is mandatory following therapy for upper tract disease. Controversial, the role of narrowband imaging and fluorescence for upper tract disease remains unclear. The benefit and route of administration of intracavity installation also remains unclear. It appears to work best for carcinoma in situ, but again, this is all based on retrospective. I did not talk about this for the sake of time, but there may be a role for an intravesical dose of chemotherapy post-nephrectomy based on the randomized trial that was published